Okay, now we'll continue from the previous video on complications of peptic ulcer disease. In the previous videos, if you haven't watched it, you should go back and refer to it. So we've talked about gastritis and also peptic ulcer disease, and now we're talking about the complications. So the complications include, firstly, perforation. The second complication is gastric outlet obstruction, and the third complication is bleeding, which we will not be talking about in this video. But first, let's talk about perforation. So when perforation occurs, the content of the stomach escape into the peritoneal cavity, leading to peritonitis. This is more common in duodenal than in gastric ulcers and is usually found with ulcers on the anterior wall. About 1/4 of all perforations occur in acute ulcers, and non-steroidal anti-inflammatory drugs are often incriminated. So um, NSAIDs um, the most are often the cause in acute ulcers and perforations in acute ulcers. Perforation can be the first sign of ulcer, and a history of recurrent epigastric pain is uncommon. The most striking symptom is sudden severe pain. Its distribution follows the spread of the gastric contents over the peritoneum. The pain initially develops in the upper abdomen, which is where the stomach and duodenum are, in the upper abdomen, and rapidly becomes generalized. Generalized means in all areas of your abdomen, all 9 regions or all 4 quadrants is termed as generalized. Shoulder tip pain is caused by irritation of the diaphragm. So your diaphragm is the uppermost layer of your abdominal cavity. Let's look at the anatomy of abdominal cavity. So as you can see here, the diaphragm is the highest level. Here, above the liver is where the diaphragm lies. Up here is where the diaphragm is. So when your gastric contents come out from your stomach, it spreads to all over your abdomen, and it can also irritate your diaphragm. And because the nerve supplying the diaphragm is sharing the same root as the nerve supplying the dermatome of your shoulder tip, the skin on your shoulder tip, when you have irritation of the diaphragm caused by the gastric contents, it will cause shoulder tip pain as well. It is known as referred pain. Okay. The pain is accompanied by shallow respiration due to limitation of diaphragmatic movements and by shock. Right. The abdomen is held immobile and there is generalized board-like rigidity. It's because whenever parts of the abdomen move, it causes intense pain, and so your muscles will contract and try and prevent any movement at all. And then when you do an abdominal examination and you try to palpate, you try to press down on the abdomen, it feels like a cardboard. So it's termed as board-like rigidity. Bowel sounds are absent, and liver dullness to percussion decreases due to the presence of gas under the diaphragm. So bowel sounds absent, and that's because the intestinal movements are not there, and liver dullness to percussion. Since your gastric contents is not just gastric acid, it's not only gastric acid, it's not only the digested food in your stomach, not only the chyme, but there's also some air inside the GI tract, in the gastrointestinal tract, which will escape into the abdominal space when there's a perforation. So this air is less dense than all the other fluids in your abdominal cavity, and hence it will go to the highest level, which is right under the diaphragm and above the liver. So you have air under the diaphragm, and when you percuss the liver, which is a solid, is usually very dull, and when you have air under the diaphragm, there's a mix of air and solid in this space over here, so your dullness to percussion will decrease, so it's not as dull as it normally is. After some hours, symptoms may improve, although abdominal rigidity remains. Later, the patient's condition deteriorates as general peritonitis develops. In at least 50% of cases, an erect chest X-ray shows free air beneath the diaphragm. If not, a water-soluble contrast swallow will confirm leakage of gastroduodenal contents. So if you can do a chest X-ray when the patient is standing, that's what's meant by erect. So when the patient is standing, do a chest X-ray, and you will see air under the diaphragm, because when you're standing, the highest part is below your diaphragm. But if that doesn't show air beneath the diaphragm, you can test it by asking them to swallow something that has a radioactive component, and then the swallowed content will leak into the abdominal cavity, and you can see it through X-ray. That's what's meant by a contrast swallow. So not really radioactive, but a drink with a contrast dye, which you can see with an X-ray. After resuscitation, the acute perforation should be treated surgically, either by simple closure or by converting the perforation into a pyloroplasty if it is large. Let's look at what pyloroplasty is. So this is pyloroplasty. On rare occasions, a polya, partial gastrectomy, is required. Polya. No, not this guy. I guess you just resect part of the stomach. Partial gastrectomy is required on rare occasions. Following surgery, H. pylori should be treated if present and non-steroidal anti-inflammatory drugs avoided. Perforation carries a mortality of 25%, reflecting the advanced age and significant comorbidity of the population that are affected. So the reason mortality is this high is because it usually happens in old people who have lots of comorbidities, which have other diseases, advanced age, old people. So that's perforation, and now we'll be moving on to gastric outlet obstruction. The causes of gastric outlet obstruction are shown in box 22.45. So just let's have a look. So gastric outlet obstruction can be caused by fibrotic stricture from duodenal ulcer, pyloric stenosis, edema from pyloric channel or duodenal ulcer, carcinoma of the antrum, cancer of the antrum, or adult hypertrophic pyloric stenosis. So we've looked at the causes. The most common is an ulcer in the region of the pylorus. So this is the most common one, the fibrotic stricture from duodenal ulcer. Or is it this one? No, it's not edema. Stricture. The most common is an ulcer in the region of the pylorus. Ulcer can cause edema as well, and ulcer, chronic ulcer, there'll be fibrosis, and it might cause a stricture. So these two are the most common cause. Okay, the ulcer is the most common cause. The presentation is with nausea, vomiting, and abdominal distension. So any GI problems, mostly you have nausea and vomiting, and in this case, abdominal distension. Right, because this part of your abdomen, the gastric outlet, this part of your abdomen is blocked. There's obstruction over here due to the ulcer, due to the fibrosis, due to edema, which is swelling of the walls of this part here, which causes obstruction. Anything that you eat or drink cannot get through here, and hence your stomach will stretch and stretch and stretch, and that's what is meant by distension. And once it becomes and then it'll become really distended. So this distension will cause nausea and also vomiting. Whatever you eat will be vomited out. Large quantities of gastric content are often vomited, and food eaten 24 hours or more previously may be recognized. So whatever you eat, you vomit out, and you may be able to recognize that's the food that you just ate about 24 hours ago. Physical examination may show evidence of wasting and dehydration. Yeah, because the food cannot get into your small intestine, which is where all the absorption of the nutrients occur. So you have wasting, which is your muscles getting smaller, your fats getting digested away, metabolized, not really digested, and dehydration, as the water cannot pass through here. Water is usually absorbed in your intestines as well, especially your large intestines. But if it can't get through this stage here, it will never reach the large intestines. A suction splash may be elicited 4 hours or more after the last meal or drink. Succution splash. It's called a succution splash. I think I've searched. No. Let's look at succution splash. Succution splash. So this is how you do a succution splash. Okay. So you auscultate and you shake the body, and then you hear the gastric sounds. But that sound there is just artificial sound. Right, where were we? Succution splash. Okay. Visible gastric peristalsis is diagnostic of gastric outlet obstruction. I've seen that. I was having that. Yeah. Gastric outlet obstruction causing peristalsis. Well, this is the gastric peristalsis. You can see that this part here is the stomach. You can see there's waves going down this way, trying to push food into the intestines. Okay. Right. Loss of gastric contents leads to dehydration with low serum chloride and potassium, and raised serum bicarbonate and urea concentrations. This results in enhanced renal absorption of sodium in exchange for hydrogen ions and a paradoxical aciduria. Endoscopy should be performed after the stomach has been emptied by a wide-bore nasogastric tube. So you put a tube through the nose into the stomach and empty the stomach contents. After that, you do an endoscopy. Intravenous correction of dehydration is undertaken. Since the patient cannot absorb water through their gastrointestinal tract, you give them fluids through their veins, IV fluids. And in severe cases, at least 4 liters of isotonic saline and 80 millimoles of potassium may be necessary during the first 24 hours. In some patients, proton pump inhibitors drugs heals ulcers, relieve pyloric edema, and overcome the need for surgery. See, so in some patients where their gastric obstruction is caused by edema of the pyloric channel, you can give proton pump inhibitors to reduce the edema. Proton pump inhibitors will reduce the gastric secretions, and when the gastric acid in the stomach is reduced, it will cause less irritation to the gastric walls, to the peptic ulcer over here, and hence less inflammation, and then the edema might be reduced, might resolve, and you don't have to do surgery, and the obstruction will be removed. There will be no more obstruction here once the edema is resolved. Okay. In some patients, PPI drug heals ulcers, relieve pyloric edema, and overcome the need for surgery. Endoscopic balloon dilatation of benign stenosis may be possible in some patients. So you insert something down, you insert a balloon down and you inflate it here. It might be possible in some patients, but in others, partial gastrectomy is necessary. So gastrectomy means you cut the stomach and you remove the stomach. Partial gastrectomy means you cut and remove part of the stomach, not the whole stomach. Although this is best done after a 7-day period of nasogastric aspiration, which enables the stomach to return to normal size. So before you do the endoscopic balloon dilatation or gastrectomy, it's best to do a 7-day period of the nasogastric aspiration. So you put a tube down the nose into the stomach and then aspirate, means draw out all the stomach contents for 7 days so that the stomach can return to the normal size. A gastroenterostomy is an alternative operation, but unless this is accompanied by vagotomy, patients will require long-term PPI therapy to prevent stomal ulceration. So gastroenterostomy. Gastro means stomach, entero means small intestine, and stomy means hole, or a hole. Gastroenterostomy means an artificial hole is made between the stomach and the intestine. This is obviously done by surgery. So let's search for that, see how it looks like. Gastroenterostomy. So this is how it looks like. This is the stomach, this is the small intestine, and they create a hole between the stomach and small intestine. Gastroenterostomy. So when you do gastroenterostomy, you either have to do vagotomy, which is cutting of the vagus nerve that supplies the stomach, or you have to give long-term PPIs, proton pump inhibitors, which reduces the secretion of the stomach. If not, it will cause the ulceration of the stoma here, because this is an artificial stoma, an artificial hole between the stomach and the small intestine, this part here is not designed by your body to withstand the acid in your stomach. So you have to reduce the acid in your stomach so that this part doesn't ulcerate. And how to reduce? You either cut the vagus nerve. Vagus nerve is what increases your gastric acid secretion. You cut that off, you reduce gastric acid secretion, or you give long-term proton pump inhibitors. So you eat a pill every day to reduce your gastric acid secretion. This is to prevent ulceration over here. And I think that's all for gastric outlet obstruction. And then there's bleeding. That's the third complication of peptic ulcers. So remember, peptic ulcer disease complications, you can present as perforation, or you can present as gastric outlet obstruction, or you can obviously have bleeding from the ulcer. And when you lose too much blood, you go into either you have chronically losing little blood, which causes iron deficiency anemia, as your red blood cell production is not able to keep up with the blood loss, or the sudden acute bleeding of large amounts where you might vomit blood or go into shock, where you lose too much blood and your volume of blood is not enough to perfuse all the tissues in your body and maintain blood pressure. That's when you go into shock, and that's another emergency. Right, I think that's all I have for you. Thank you.